Our objectives for this Safe Mama Tech, we called this Safe Mama Tech. And one, we wanted to harness the digital connectivity and interoperability. We wanted you to go to each of these facilities and never get lost. So whichever place you go in, that data gets in, it still goes into your book. Then we said we are going to do something called value-based healthcare for these mothers, which means for every step you take, you are going to get a value. From the time you get pregnant until the child is immunized, that's a full journey. And so we measure how well is that journey. And everybody along that system gets incentivized. The community health worker, the health facility, and the mother herself for that journey. So if you do a good journey, all of you get incentivized. The third thing is about building private-public partnerships. And in our first ward that we did, we made sure that all the facilities which are private did an MOU with us that we are now joining this program. These are the outcomes that are required out of us. This is my contribution. This is the government contribution for us. And finally, we said we're going to replicate this model across all our PCNs. Next slide. So, this is what we have. We have our interoperability layer down there, and down, I think this is the simplest diagram that we have. This is a very old diagram. We say that all the tools must be able to talk into this interoperability layer so that everybody can be able to see. Next slide. This client registry actually shares a lot from the national government because the client registry is getting your unique identifier from the national government. One of the failures of it is because it uses your ID card. So people who are less than 18 has still been a problem, but they will still get some identification because our base EMI, where the HMIs that we are using is called Kenya EMR, it's a part of the Taifa Care. It already has a unique identifier, whichever place you want. But we don't want you to go to the next facility and be re-identified. When we started, we were seeing almost 10,000 women. And you're wondering, how do you get 10,000 women in one small ward? And what was happening is that it's the same mother going to different facilities. She went to this facility, she didn't get iron. She went to the next facility to get iron. So she was registered there. She got her iron. She came back. This time she decided she's going to the market. I'm going to do this. So people were triple, quadruple registered. Once we did this interoperability layer, I think we have really eliminated that. Now we have correct numbers of who is who and who is where. The next slide. Now this is what I talk about, a maternal journey. Starting from antenatal. We want to encourage you, if you start your antenatal clinic before you are 13 weeks, and you make sure you come for all your clinics, and you deliver in a facility, and you have a good baby, and you score and say, I'm very happy in your exit interview with whatever happened, and you bring your child for all immunizations, then that is a 100% score. And that 100% score gives you an incentive. Use the mother, you get a bag and a package. You, the community health worker, for that delivery, you get something. And at the end of it, something is given to the community health worker for making sure that mother goes through the whole of that journey. And that's what a whole journey is about. So safe delivery and adherence to postnatal care. But behind this is ensuring that those facilities have quality. So these are done by several partners. We have Farm Access with the Safe Care. We have Wanda EMR, which is basically paid for by Kisumu. We have digital AI-enabled ultrasound, which is from another company. So all these technologies have been brought together. So this is just a slide of what we've been able to do over the last 1 year to see that now we can talk about 1,800 mothers having gone through our system. Deliveries, 1,187 antenatal visits, and 812, so it's 1,800 visits, and 812 deliveries. So far, we've had, we have the yellow alerts and red alerts. Sorry, I don't have those numbers very well. We had one maternal death and actually an elective cesarean section, very, very sad, out of all these mothers who went in. We had several mothers who were red alerts. Red alerts means that you were seen in the system and it flagged you as red, all right? And my colleague will talk about them. So we were able to improve on that. And what I want you to see over this side is the amount of money earned so far by these facilities. That because they started, when we started, it was a little bit low, but they have added 2.6 million so far. And MCH value so far is around 2.3 million shillings that has been given in terms of incentives for these deliveries. Next slide. This is our dashboard for quality analytics. I didn't talk about quality. Each of these facilities is enrolled into a quality improvement program, which is digitally captured. So once you enroll yourself in the first thing you do is you score yourself. Then you get a team of guys who come to score you. All right? Now that enters into your records. Once you are scored, you are told these are the things that you didn't do well. And so these are the things that you're supposed to do well. When you implement these things, we come and score you again, and then we see this is how we have improved. Now, from there, we're able to see in the dashboards who is performing well, who has done 50% of his issues, and who has done 30% of his issues, and all that kind of thing. I think that could be my final slide. Next. So this is an example of a Safe Motherhood program, which my colleague will talk about later in detail. But we have another one, which is now dealing with community health. That we realized that when we started doing our community health, our numbers of hypertension and diabetes went up 3 to 4 times. And so we said this area, which has high diabetes and hypertension, we are going to have a program with them. And so we partnered with somebody who has done something in community health, what we call Health Entrepreneurs Program. And we co-designed a program with them. So they have an application, and we have community health workers. So we leverage on these community health workers. You train, you retrain, you make sure they're doing the right thing. So they're able to follow up these mothers up to the village, and these people up to the village, take their blood pressures, take their random blood sugars, and through that, have telemedicine with the clinician. So the clinician is seated somewhere at the comfort of his home, gets the information, gets to talk about the patient, gives the patient. And what we realized is we had a huge number of clients in the villages who simply don't go to the facilities. Why? They're old. They're 65, 75. He has arthritis. Telling him to panda a piki to go to the next facility, he doesn't go. Now, all these people we were able to capture. And that is how digitization can actually impact on people. So digitization for us is not a numbers on a dashboard. And I know numbers are very nice on a dashboard. Numbers are very good when you're looking at the forest. DHA, at the national government, they look at the forest. At the county, we look at trees. And our value is in a tree. This tree, how is it? Was it pruned? Was it getting manure? At the national level, they're looking at what is the tree coverage. So we are related and interdependent. You need the tree for the forest, but you need the guy who's looking at the forest to tell you that the forest cover is getting low. So all of us need each other. And that is what digitization has been to Kisumu. I'm very happy with what I see, looking at it from the total county levels, that many counties have innovated. Murang'a has shown us how innovation can work. We have seen so many innovations in many other counties in terms of digital health. But that is how we are going to transform this country and leveraging on digital health. With those very many remarks, allow me to close here and give it back to the chair of the session. Thank you very much, ladies and gentlemen.
Thank you so much for that. One thing that is a takeaway, and I will use this example moving forward, is that national government is a what? It looks at what? The forest, right? The forest. And then the county government looks at the trees. So what are we looking? We need to do what the trees, to prune them, right? So that is one thing I think when I leave this conference, I am going to be using that example everywhere else, just to depict the role of the national government and the county government. So at this point in time, and I know Dr. Ganda also alluded to this, we are going to be, time is also well spent. I know that we have people on the online platform. I don't know whether you can always just drop a comment in the comment section or questions. We will gather them up at the end and then also ask. Just to tell the people who have just joined us, thank you so much for making the time to come here. I will keep appreciating. For those who just joined us midway online, thank you so much for being here. At this time, we want to actually have a panel discussion. We have seen the example of what Kisumu County has, and I know a lot of technical terms were introduced as well. But then we want to have a conversation. He talked about national government. government. How does the conversation look like between national government and county level? And then the other thing is, if we want this to actually, if we really want us to actualize the digital agenda when it comes to digital health, we need one important element: pesa. Isn't that true? Isn't that true? We need to figure out how do we finance these initiatives, because we can talk about it, we can have good ideas, grand ideas, but if we don't know where the money is coming from and how the system makes money to sustain itself, then we are just building castles in the air. Isn't that right? But then we also need to talk about different communities. And for this panel, we'll be looking at young people. How do young people join into this conversation? We want to put all this representation in a panel and have a conversation, an open and candid conversation. Pay keen attention, write down your notes. We'll be definitely coming back to you to hear your thoughts and insights on the conversation, as well as any other questions to follow up on the conversation. I would like to invite my colleague Martha, who will be taking us through the panel discussion. She will come up, she will introduce the panel members as maybe a short introduction, and then the panel members might also elaborate on their profile before they speak. But at this point, we're going to hand it over to Martha. So a round of applause to Martha as she comes onto the panel.
Good afternoon to everyone. Good afternoon to the team online. You're welcome for this session. So I have a list of 4 panelists that we want to have this broader discussion on digital health as an enabler and driver of equity in devolved systems of government. We are in the Devolution Conference. We know that health is a devolved service in Kenya. So we want to see if there's equality in provision of healthcare services. We want to know specifically what KELIN, DHRP, and KCAT are talking about when they're talking of paying the costs of connection. So I want to invite the panelists. I will start with the Kisumu County Health CEC, Dr. Ganda, to come back here. And I see that he has sent a representative as he catches a breath. Karibu sana. We have Winnie Gift from the Kenya Community Advisory Team under the Digital Health Rights Project. We can clap for them as they come. We have Dr. Joyce Wamishwe from the Digital Health Agency. And we have Stephen Osedo, the Executive Director of the Center for Fiscal Affairs. So we can clap for them as they come in. Thank you, Pauline. Encourage them. And we are also welcoming people outside to come and join us as we have this conversation. Karibuni sana. It's very bright. I think we can... okay. You're welcome. So I want to give the panelists the mic to also just briefly introduce themselves and maybe tell us why they are passionate about digital health in 30 seconds. So we'll start.
Thank you so much. My name is Agnes Dawa. I work at Kisumu County. Currently, I'm the Primary Healthcare Division lead. I'm passionate about this because of what digital health and the innovations that we have within the county has done to the outcome of our mothers and children.
Thank you very much. We can have Gift introduce herself briefly and tell us why she's passionate about digital health.
Oh, hi. My name is Gift Winnie once again. I'm happy to be here. The angle I love is young people. I'm a young person, so I love young people. I feel like it's majority of us in this nation. It's majority of us utilizing digital technology. So I'm happy to be here speaking on behalf of young people. Thank you.
Thank you very much. Winnie Gift. We'll move on to Dr. Wamishwe.
Yeah, so good afternoon, and it's been a long day, but we are here.
Yes.
Anyway, I am the technical lead at the Digital Health Agency. I know I've met many of us in this room. Why do I like digital health? Because I've been implementing it somehow. And I mean, from the days of the HIV program, a bit in private sector as an end user, and now really as somebody who's trying to see what kind of solutions can we take out there for both the patients and the healthcare workers, and how can we do the integration to make it work. And so I know that what we are doing is what we would call creative disruption. So it's exciting implementing this, but I'm also implementing it because I know it has an impact, that it will, at the end of the day, it will tally back to whether quality healthcare is provided, yes or no. It was really exciting to see what Dr. Ganda just showed in his presentation. And I'm like, where were the people for the quality of care bill? They should have known that you are actually implementing. And I'll make sure that I go out and say that you should talk to Dr. Ganda about this. So digitization has got the capacity, the potential to impact lives, and definitely in healthcare. Thank you.
Thank you, Dr. Wamishwa. We'll move to Stephen Osedo.
Thank you very much, Martha, and good afternoon, everyone. My name is Osedo. Stefan, as I've been introduced. Why am I passionate about digital health is because, one, it's about the people. It's not about the systems, the tablets, as the doctor was telling us. It's about enabling access to quality healthcare to the people. And as somebody who works very closely with the communities, so it's an area that I draw a lot of passion around. And also just to ensure that whatever solutions that we come up with have the people in mind. So they're not being developed in some labs and offices in high-story buildings, but consultations are done at the community level, at the grassroots level, to ensure that whatever solutions we come up with respond to the needs and the interest of the people.
I want Ms. Dawa to pick up from where Dr. Ganda left off. We have heard about the Taifa Care that is being used in Kisumu County and across the country. We've heard about the value-based care for mothers and babies through the primary health care network. Maybe the rest of the participants may not know, but we have heard about Marwa and the other digital health interventions that are being implemented in Kisumu County. So are you able to briefly expound on where Dr. Ganda left off on the examples in brief of the successful initiatives that, digital health initiatives that are happening in Kisumu County, or at least the ones that Dr. Ganda didn't mention, and base your answer on the actual success, because we know in every initiative, not all of them happen successfully 100%. Thank you.
Thank you very much. So out of all the interventions we've had, with Wonder Health, we started at the antenatal. We want our mothers to come in on time, that's at least before 12 weeks of pregnancy, so that we are able to walk the journey together for 8 antenatal care visits. We begin this in good time, and then with every visit, it is fed into the system. If there's a need or something that needs action, then immediately it's flagged. And we know this is a red alert and we need to take immediate action. The beauty of this, that even if you're alone at work, you're able to be told what to do. For instance, if it is a high pressure, you're in a dispensary, you're told to immediately refer to a tertiary facility. So we are also having interoperability from the community up to the facilities in respect to the same. We also have the yellow alerts. Yes, not so bad, but still need some action to be taken and follow up also for the same. Then we also have the artificially enabled digital the ultrasound, which we are doing. We are trying, because WHO wants us to do at least 2 within every pregnancy, the first trimester and the last trimester. So for this, we are actually working towards strengthening leadership and governance within our PCNs and WPGs. And also this has helped us from the two projects I've talked about in for the Safe Mama Care, as was projected. We saw about 1,800 who were enrolled into this. And out of this, only one maternal mortality, but the other outcomes were good. Then when we move now to the Wonder program, the project rather, where more mothers were put into the system antenatally, we had over about 8,700 mothers into this. And out of all this, who were flagged out antenatally, all the outcomes have been good. We've not had any maternal mortality. We have not had any neonatal mortality because of this particular project that we have put in this particular system. So we have many projects within that particular one just to, at the end of the day, have a good outcome for these mothers. With the Safe Mama Care, we are working with these mothers. We want them as early as maybe 12 weeks, and then we work together for 18 months. Meaning we are looking into issues about quality of care, we're looking into antenatal attendance, we're looking into outcome, immunizations, family planning, postnatal care, and the like.
Thank you very much, Madam Dawa. One more question for you. Are there any lessons from this digital health transformation period that Kisumu has been going through? Any lessons that you would want to share for the prosperity of the people in the devolved healthcare system that we are currently having in Kenya?
The lessons learned through implementation and ongoing, one is that it's actually a community-centered design whereby we are co-creating solutions with the healthcare workers, the pregnant mothers, and the community at large. Then we also have integration with existing health systems. For instance, what we have on board is just riding on what is already within the system. Then capacity building and mentorship to our healthcare workers and our community health promoters for them to be able to understand the digital tools that we do have. Then data-driven decision making. Data, well, that is what it is meant to be for. So for this particular cases, it really helps us. We even have a WhatsApp group that we have created where we are all on board to include the CECM. So anytime there's an alert, everybody's head is up. What was done? What is the outcome? So it's an inclusive program that we have put on board. Then also lastly, partnerships for scale. We have different key players and stakeholders within this system. We have the partners supporting us. We have the county government itself also supporting the system, having its staff trained, and also the partners working with us just for the good outcomes that we are seeing in respect to the same.
Thank you very much, Madam Da. And I want to move over to the Digital Health Agency. Based on the experiences, the wins, and the grow areas when it comes to devolution and the devolved system of government, how is the Digital Health Agency dealing with infrastructure, capacity, policies, within counties? How is it promoting that? We had a session in the morning whereby we were learning of where the Digital Health Agency has moved from the beginning when it started last year. So what preconditions must counties meet for effective digital health integration?
Okay, thank you, Martha. When I saw that question, I laughed because I wondered, okay, tumefika mahali pa preconditions. So I don't think the Digital Health Agency looks at it as preconditions, but I would call it, when we see a county having certain things, then we know we are going to have an easy time. And when we go to another county and we see certain things, then we know here we have to do some heavy lifting. So what we are seeing now is not anything different from what we saw when we were implementing the HIV program in the public sector, the rollout of Kenya EMR. And I bet it's not any different from even the private sector. The only place I have seen things happening because they have to happen is the KDF sites, the Jeshi, because there it's AMRI. But there's also, that's another discussion for another day. Should you force? Should you put your foot down and say you must, or should it be a discussion? That's something that I think Kelly should try and look when we can discuss. But back to the preconditions. So number one, the most important thing is intentional leadership. I was actually, Pauline was whispering to me and telling me she's planning to do a thesis in her postgraduate on something to do with digital health transformation, the Digital Health Act vis-a-vis the maturity of digitalization in counties. And she mentioned maturity, and I told her, if you look at what you're calling maturity and go back and look at the kind of leadership that is there, it is equals to, it's you can always like say this county has moved because of the leadership that has been moving this agenda. So leadership can either be at the very, very top, like now we are able to do what we are doing because we have the highest political will. But even at the county, if right from the governor, the CECs say that this is the way we are going to go, then that things begin to move in a certain direction. The passion of the leaders is very important. The structures, I feel like I'm doing a recap of what Dr. Ganda had just talked about. The structures, a county without structures, and when I talk about structures, we are urging counties to have two key structures. So a STEERCO, a steering committee that the governor heads, and this committee is called Digital Health Transformation Committee. We'll just call it like that. And then a technical committee that leads any digitalization work. But beyond digitalization, beyond putting a computer in front of a healthcare worker and having that healthcare worker use that computer to see that patient, we anticipate that these are the same committees that will drive data use, because there's no need of doing all this work and you're not utilizing the data that you collected. So these committees will grow into data use committees, into operational research committees. It is something we have done. We did it when we were in NASCOP, and it is what we are really pushing for counties to have. So intentional leadership is one. Number two, it's about champions. So you can have leaders who are saying, yes, this is the way to go, but kutoka hapo, kwenda chini, there's no champion. So we urge counties to identify their champions. Who are these people who are champions for digitalization? The champion doesn't have to be seated at the CHMT level, doesn't have to be seated at the county health, up there. The champion can be that facility in charge, at a dispensary. Those are the people you bring to the fore so that they are able to speak to their colleagues and tell them, hey, this thing works. You don't have to get scared about implementing digitalization, for example. The third thing is about understanding your county. You have to understand your county, how digital health ready it is. We've been pushing the counties to do this through having them do a baseline health facility assessment. So from there, they are able to understand how many facilities they have, which facilities are digitalized in the corners. Maybe they have a partner who has a laptop in the corner collecting something, or they have end-to-end digitalization. It is during this time that some counties discover, haya, kumbe we have SPICE, for example, that's already rolled out in certain facilities for purposes of NCDs. And then understand infrastructure readiness, assess whether you have enough human resource. So it's quite detailed. But it is that helps a county to define its plan. How is it going to digitalize? So some counties already have a system. Maybe the system is in a corner. So it's Kenya EMR that was being used for HIV. So to expand digitalization in that health facility is easier than in a facility that totally doesn't have anything. So once the county understands that this is how we are, then they create a plan that this is how we want to move, and we are going to move in these phases, and by such and such a date, we will have digitalized all our health facilities. And for the ones that need some really, really heavy lifting, we are able to define to the national government that this is what we are requesting. But you cannot start asking for help when you don't understand your terrain from a digital health perspective. Then the other one is just appreciating that we're in a different space. I'm saying this cautiously so that James Kamau doesn't look at me badly, but we have to reform. We are not doing things the same way we've been doing. Case in point, for us who are in the health space, for a long time, and I was explaining to another county today, just a few hours ago, NHIF was for the billing clerk. Me as a doctor, when I sign that karatasi and I write your diagnosis, I'm out. I don't even want to know whether the facility was ever paid. Sijui what intervention is that? What is the tariff? I have no idea whatsoever. But today, as a doctor, you have to know that when you are seeing this patient, what are the tariffs that SHA is charging for these particular things? If you're doing an appendicectomy, you go in, you've already done a pre-authorization request for an appendicectomy. But when you go in, you meet PASS. Things change. How then do you claim? How do you make that claim? Because things have changed. It's no longer just a simple appendicectomy. And the healthcare worker has to realize that we are no longer dealing with financial claims. You know those boring examples people used to say for NHIF, we look whether a man got pregnant and was done as CS. You know, that's not where we are. With digitization, once you say you were in ICU, then the diagnosis has to ambatana with that being in ICU. And those are the things that now this digitalization business is coming to show. So we have to change the way we've been doing things as healthcare workers. SHA and things related to SHA are no longer just for the billing clerks and perhaps maybe if you stretch it, the HRIOs, but it's for everyone in that health facility so that you are able to give the best to the patient. We have many facilities who they turn away people. The healthcare worker turns away the person because they are told, SHA haikavi, SHA is not covering. But when you look back, SHA is actually covering, maybe has got some limits, but you yourself as a healthcare worker, you don't understand. So those are some of the things that I would think about. I wouldn't call them, preconditions, but they are identifiers for success or lack of it. Thank you.
Thank you very much, Dr. Wamishwe. And I think for a long time, there was a little bit of pushback when it comes to technology because medics thought that technology will take their jobs. But I think from the first 2 points that Dr. Wamishwe has mentioned, we need intentional leadership, and leadership comes from human beings. And secondly, she has mentioned champions who are still human beings. So if there are any medics who have been fearful of digital health, we have a strong source telling us that this is actually here to help us. And with that, I want to move to gifts. Through the Digital Health Rights Project and through the Kenya Community Advisory Team, based on the report, maybe first you can briefly tell us about the report. I know you mentioned the report that the KCAT did, but if you can also just tell us in relation to the report, what are the biggest human rights risks in Kenya's digital health rollout, knowing that the right to health is a human right that is being enjoyed by all Kenyans and others across the world. What can you tell us about the report and the biggest human right risk when it comes to digital health rollout? Thank you once again, Martha, for this opportunity to speak. What I would say is the Digital Health and Rights Project appreciates how the digital revolution, what the digital revolution is doing to the world. And it is happening everywhere, in every single sector, in one way or the other. And healthcare is just part of it. So the Digital Health and Rights Project is saying, yes, we agree. So many nice things are happening in the digital sector. But again, it is also recognizing that what is the weight that is coming with all these inventions, what is the weight that is coming with all this tech, especially particularly in the healthcare sector. So when we were doing the project, we were analyzing how human rights is intersecting with technology. And we were able to identify some key human rights issues that came up from the young people. So I will begin by mentioning the first human rights issue was the issue of access. I'm quoting our Article 27 of the Constitution that is guaranteeing each and every person, human being, guaranteeing the right to equality. We are all equal before the law, and we are entitled to equal protection and benefit under the law, as well as equal enjoyment of all rights. We are all saying digital health is a right. So we are saying every single person is entitled to enjoy this digital health revolution that we are talking about so much. So the issue of access comes in when young people are realizing that some people are being left out for various reasons. First of all, digital health cannot work without digital devices. For you to access digital health services or information or anything digital health, you have to have some form of device to access the service. And we did, when we were speaking to the young people, we realized they don't even have these gadgets in the first place. So we are rolling out so many nice new things are coming up, but are they really benefiting each and every person? So some young people are being left out. They don't have smartphones. They don't even have kabambes. If we are talking even of free USSD, they don't even have kabambe phones. And even for those who do have smartphones, they are saying we don't have data. We have smartphones, but it's very difficult for us to prioritize data because of different economic challenges. It's not really a priority for them. And even for those who have smartphones, do they even have the literacy to understand how to navigate digital platforms? Do you know where to go to access this health information? We are mentioning so many nice apps. Is there enough, are we loud enough about these apps so young people can know whether there are these apps? Young people in the reproductive age can know these are the maternal apps you can go to, these are the SRHR apps that you can access. So there's a really challenge also on the infrastructure. We have areas where there's very limited technology to say like some areas are saying we don't have network, like for example, for Airtel. Like I use an Airtel line and we don't have such network here. So it's a challenge. So the issue of access really came out from our project. Also, another human rights issue that came up was the legal aspect of digital health and rights. So in this part, we're asking ourselves, okay, of course, we cannot exist blanketly. We need laws that are going to govern the digital health in some sense, in how is it being utilized, how are making sure people are safe online, the data is being protected, and in case of any violations, where do we even go to for these violations? So we appreciate that there's progress in terms of coming up with digital laws, but we are saying progress, of course, is not success. There is so much room for growth in that area. Some legal aspects are overlapping one another. The Digital Health Act came about. It found the Cybercrimes Act already existing, and the Cybercrimes Act already found the Penal Code already existing, and the Children's Act, and they're all covering some overlapping issues. So how do we make sure those issues are just integrated? So it's not like one law is very different from the other. We just have a good systemized process where you just know if I have an issue with this, I can go here. And there's nothing that contradicts that. Also, this aspect of the legal aspect, we realize that young people are not even aware. We were asking them, "Oye, do you even know the AI strategy?" They are clueless. Do you even know we have a Digital Health Act? They are clueless. Do we even know we have a Cyber Crimes Act? they're clueless. Of course, not all, but some were clueless. And we realized that this is a gap because these laws are for every single person. And if young people, especially the ones who are using this digital technology so much, they are not aware of these laws, then it raises some very serious human rights concerns. And so even for the young people who knew the law, they also know they need to know the recourse. Most of us know there's the Cyber Crimes Act. If somebody harasses you online, you can do this. But how many times do we even go and report this offenses? Somebody has harassed me online. Also, our law enforcement, are they aware of how to handle such issues? I'm going to tell a police, there's somebody who has laughed at me because I have asked on how to get services for an STI. They're probably going to shame you. They're probably going to laugh at you. So we sort of also need a training around law enforcement officials to know how to handle issues with regards to digital health and rights. And also something that I feel the counties can really come in to support is also the angle of language justice. We have these laws, but honestly, not everybody is savvy enough to understand the technical terms that come with the digital rights. And also not everybody is able to understand English. I'm borrowing from the recent controversial finance bill, and you remember it was translated to very many languages. And I don't think we ever have in this country that level of public participation in any bill before. For what I know. So it was really inspirational to see what public participation is able to do. So mine is, so what we picked up is there's need for language justice. These laws, let the counties find a way to translate these laws in the best way possible for young people to understand it and in the language that is mostly used in these counties. So another human rights issue that came up was safety online. Do young people feel safe online, especially marginalized groups? There's persons living with HIV. We have sex workers. We have MSMs. All these people are guaranteed the right to health, including the right to digital health. So do they feel safe online? So one thing that we were asking ourselves in terms of data protection was when we go online, so we're asked for so much information. This is the report by young people. They're saying we go online, we're asked about so much information, our names to log on to platforms, our IDs, email address, they ask you your sex, your gender. Sometimes you're even wondering how it correlates to the service that you're seeking. So we're asking ourselves, who is keeping this data? And I think that would be something that I would also want to hear from the Kisumu County. Like, how are they ensuring safe data protection? How are they making sure that the data that they collect is only accessible to those who need to access it, and it does not have to get into the wrong hands. So who is keeping this data? Why do they need this data? There are so many principles of data protection. You minimize, you only pick the data that you need. Stop asking people to give you data that you do not need. So are we ensuring, even in our counties and the platforms that we are creating, that we only pick data that is necessary from the people? Also, what happens after you no longer need this data? How are you disposing of people's data? Are you letting them know as you receive it that this is the plan? Once we are done, this is how we are going to dispose the data. And if you need to share the data with a third party, are you informing them that, by the way, Red Cross need your data? Because sometimes data is needed for the right reasons, but at least consult the owner of the data before you share it. Because one thing that was coming up in our data collection was that young people were saying, we don't understand how we get random messages from, for example, Red Cross that I've mentioned. It's a really good initiative that they are warning you, there is floods, avoid this area. And then also, but like, who gave you my data? I've never spoken with Red Cross before. I don't know how you even have my number. And it even goes beyond that. Also, when it comes to advertisements, betting companies have been on the map when it comes to taking people's personal data without their permission. And much as we are blaming them, also we need to blame the initial people who have the data. Why are you sharing people's personal data without their consent? So these are human rights issues that are coming up. Also, the issue of surveillance. It was interesting to hear that young people are mostly worried about surveillance by close family and friends. We would have thought that maybe it would be government surveillance or tech companies because they have the machinery and the power to find you and to get your data. But most of them are saying, honestly, I don't even care that much if the government has my data. But I don't want my family or my partner or my friend or my neighbor to access my data without my permission. Meaning there is a whole stigma around it because they feel the government doesn't really know me. But for my family, I don't want my family to know I'm HIV positive unless I am willing to share. I don't want my family to know my gender identity unless I am willing to share. So these are challenges that are also coming when we are talking about data safety. There's a lot of phone sharing among our counties, and that's a really huge point of concern because people are sharing phones, and during that exchange, you access people's search histories and their messages and such kind of things, and you're able to conclude who they are. You're able to create a bias of who they are, and all of a sudden now the information is out there. Your status is being outed, your gender status, your health status, and this was a big point of concern in terms of surveillance. Also, surveillance by tech companies. Maybe the counties need to think around it of we are online. There's a lot of algorithm bias. Like today, you're searching, how do I treat this STI? And all of a sudden, when you're searching it, maybe on Google. When you go on TikTok, your whole FYP page is just talking about STIs. Your whole Instagram, and you're asking yourself, how could they have figured out that I was asking Google about how to seek a treatment on an STI? And so this raises concerns because you're like, somebody is checking me out somewhere. Somebody is surveilling. And maybe just because I asked it once, doesn't mean I want you to flood my whole timeline with issues of this particular issue. Something else that came out was also government surveillance. Young people are saying, yes, we feel surveilled by the government, and sometimes it is scary, especially for criminalized groups. So they're saying, I'm unable to go online and be honest and say, I'm a sex worker and I want you to help me. How do I get PEP services, PrEP services? I'm an MSM. How am I able to get SRHR information around my gender identity? And they're scared. Maybe if you do that, information may land on the wrong hands of the government. And for these criminalized groups, this is, of course, this is dangerous for you because you might end up being arrested or anything around that. So, all these are boiling down to privacy concerns, which are guaranteed in our constitution. And the last part I would talk about is stigma. Stigma was honestly intersecting with every area that I've spoken about. Stigma was the bottom line. Like, there's self-induced stigma. There's that stigma that, you're feeling stigmatized from other people. And then there's that one for yourself, like you're scared yourself. The way I've mentioned it, if I go online and I'm a person living with HIV and I start this thing and my sister sees it, how will they behave? Because we had people talking about they no longer want to be sent prompt messages telling them to go and pick their drugs. It's a good thing to be reminded to go pick your drugs, but they're saying sometimes my partner is using my phone, they don't know my status. Sometimes my mother is using my phone, they don't know my status. And they end up saying, you're supposed to pick your drugs by 5th of, and they're asking themselves, now just like that, your status has been outed. So on stigma, we felt like the counties have a responsibility towards creating awareness around social responsibility, understanding that gadgets used for personal use, just make sure you don't, it's something that people need to be reminded. I've learned also a lot through the research cycle. And it's just like even when somebody gives you their phone, you just take a responsibility with yourself to make sure that you do not try to get, it might seem normal, but honestly, there's a need to raise awareness around how we interact with people's devices and information. Also on stigma, young people were reluctant to go online. So this is a human rights challenge because we're saying digital health rights are a right it's a right for everyone. But if a certain particular group is scared to go online to access services and information that are there for them, then this is a human right concern. And so it is a call upon the counties to figure out how do we create a really good balance to ensure young people have the devices that we need. Do we need to speak to tech companies to help us in this area? Who do we need to consult? Who are the right people? Do we need a form of advocacy to make sure that all these human rights concerns are addressed? Yeah, so that's basically what came up in our research.
Thank you very much, Gift, for that information. And I want to move to where you directed the question, Kisumu County. You've spoken about red alerts and yellow alerts for mothers. And I want to ask a question based on the other marginalized communities. How are you ensuring that they're able to access these digital health services? And how are you ensuring safety when they are accessing these services? And the question will also go directly to the Digital Health Agency. How are we ensuring privacy and data protection when we are implementing digital health or when we're in the process of rolling out digital health from the national level? So I'll move on to Kisumu County first, then Dr. Wamishwe can join in to tell us about data privacy.
Thank you very much. Well, as a county, we have digital health initiatives that are in place to include the Kenya EMR that we are using. And we also have data protection measures that are in place. We equally do what we call strategic partnership with the implementing partners that we have on board. So anytime that there are issues around data, it is not porous. You cannot easily get that data. But through maybe the program officer or whichever relevant authority would be there, then you would get, but in full context of what is to be done with that data. So I believe with the measures that we're trying to put in place for data protection, this comes out. Then, as I said, the projects that we have that are running in respect to mother and child care, we have the community component. Our CHPs are equally in the ground, and our CHPs cover all the areas to include the marginalized, because they are within the wards, or rather within the communities. So they can easily reach out to these particular clients and get information that they want. This has also helped us for those who are not able to reach facilities in good time. The CHPs move to the houses. Dr. Ganda talked about healthy entrepreneurs, where the community is also equally reaching to the clients in the community. And they're doing their checks, they're doing their vitals, and they're able to do it through telemedicine and get these clients to be back on track in case they were defaulters. But generally, we are trying to strengthen these systems because it is this very data that is also supporting us for making decisions. For instance, one of the very positive outcomes we had out of the SMT program that we have is reduction of anemia from 58% to 34% in that particular ward. Because of the data that we were using, we do also step in to support that ward. We have weekly meetings, virtual meetings, and we discuss this very data. What has been done in the last 2 weeks, and how can we support the particular ward to make it even better? So these are things that have also helped us. And when we're also doing these discussions, there are issues that are also directed towards the community health services. So we are working as a unit, the community health services, marrying very easily into the PCN structures that we have. Thank you.
Thank you very much. Dr. Amisha?
Yeah. So as DHA, of course, you expect us to bombard you with a response that goes like this: data is encrypted, at rest, moving, sijui, servers, firewalls, all that. Yes, we have all that, okay? And we are building a system with security as part of the design. We are also learning from people who have been hacked until they like hacking is part of their job for some people, even in those companies, the banks and the telcos. We are also learning from them. But the main thing that I would want to leave us with is that the weakest link is not what DHA is covering. The weakest link is the end user client. So we have the patient, and I think my co-panelist has really brought that out. Your phone, there are many things you're going to be accessing through your phone. Are you digitally literate to understand that as much as we can say we are going to send you, I don't know, can you send encrypted data, which upon now you put a password? George, is that possible? And then now, we can make it more difficult for someone once they get into your phone to get your data. But the most important thing is you who has the phone, how are you keeping your phone safe? So that information that you don't want people to know about doesn't get out there. Because we plan to have, a way of communicating to the patients so that we empower them. We actually have a portal called Afya Yangu portal. You can go to Play Store or Apple Store is called iOS or something, and download the Afya Yangu portal. That portal has got a lot of potential. Right now, the main use is SHA registration. But you are also now, if you are seen through the Taifa Care HMISs, you're able to see your last visit. And you're able to also, we want to add prescriptions there. At some point, we'll be able to tell this is a person with chronic disease and send them some messages to encourage them maybe to take their meds. So there's going to be a lot of interaction with the phone and the patient and the system. Through that phone, many things can be obtained about that particular patient. The other one is the healthcare worker. I always like joking that I've been to facilities where you find the tablet open, the person has gone, I can see, I'm able to get into the system. And then you just happen to ask, what's the password here? And because I'm DHA, somebody says 1, 2, 3, 4, what? And I put in, if I really want to, and it's being shouted. I mean, the person, the healthcare worker is saying it as they're in another room. So how are we ensuring that healthcare workers are also keeping their passwords safe? We know that when you go to a cyber and if you don't log off properly, you leave the way you ulingia that computer, somebody can be able to access your information. So digital literacy for patients, healthcare workers, very important. The third one is community health promoters. I have been to places where the CHP tells me, pale niko na diabetes wawili, pale kuna mama mjamzito amekataa kuenda hospitali. And they're just pointing. So when we realized that, we also said, no, even this particular group needs a lot of digital literacy. So we've in forums where we know we are going to meet them, we've been doing a lot of sensitization on data protection and why it's important to keep patients' information confidential. So the weakest link is the end. Is the downstream. And that is where a lot of data protection, or what people like to call digital literacy, is required. And DHA cannot do this alone. It is one of the responsibilities that we are telling counties, please ensure that we are working on this also together. I'll stop at that. Thank you.
Thank you very much, Dr. Wamisho. And it's important to note that the end user, which is you and I, are the weakest link. So maybe what I can say is, despite the, on top of giving digital health education to healthcare workers, I think it's also very necessary for us as the end user of these services. So a lot of public education on digital health, privacy and whatnot is very relevant for us. I want to urge our participants online to still stay with us and type in your questions. We'll be able to ask a few of them after we hear about the money matters. I want to invite Mr. Osedo to tell us about financing models of digital health. How can we sustain and support digital health adoption? And as you talk about that, also briefly tell us on how we can ensure equity in resource allocation between counties with different fiscal capacities. As we said before, healthcare is devolved, and we also believe digital health services are devolved. So how can we ensure equity in resource allocation when we are doing the county budgets? And also, how can health financing strategies incentivize inclusion and rights-based approaches? Karibu Bwana Osedo.
Thank you very much, Martha, and good afternoon again. Allow me to acknowledge one of my board members who is here, Oliver. Thank you so much, the Executive Director to Raia. So when we talk about financing in general, it's a very dicey conversation because we all know that there are two major sources of funding for our programs. So that is either through taxation or we are borrowing. And currently, you know that our pay slips for those who are employed, it has been raided. So it's a very dicey one. It's a very complicated conversation. However, allow me to say that we have seen very innovative ways adopted by different counties to finance health and in particular digital health. Despite the very discouraging allocation from the exchequer, that is the National Treasury, we have seen very good initiatives and innovations. For example, collaboration with the private sector. Yesterday, if you attended the opening, Governor for Muranga, His Excellency Kangata, mentioned the collaboration that they have with Safaricom that has enabled health access through USSD code. So Safaricom has invested in a system that allows even for the people who use cellular phones to still be able to access their platform, the digital health platforms, through a USSD code. And I would say that's an innovative way which could be adopted by other counties. Kisumu has also mentioned the collaboration with Farm Access, for example, in their system. So I would say one of the ways that we could explore as counties to finance digital health is through private sector collaboration. Two is through budgetary allocation. And again, I say this is also an area because there's a study which I alluded to in my opening that we conducted in 2023, which showed that out of the total county budgets, we did this in 4 counties. And out of the 4 counties, it was only Kisumu that had hit 1 point something in terms of allocation towards digital health. So as a total, as a total of the county revenue. So we are still encouraging counties that even as we prioritize and we know times are hard, where we have to juggle around several priority needs. Digital health is one of them that we should focus on and give more priority in terms of resource allocation through the county budgets. And that is not just something that we can leave to the counties alone, because we know that there are so many competing priorities. So we need to also sensitize our citizens to be in the forums where budgets are being discussed, so that they can also push for sufficient allocation towards digital health. The other way that we could finance digital health is through what we are calling pooled procurement frameworks. For example, we could have the national government procure a system, for example, the Kenya EMR, and then now the 47 counties just plug into that system, because we know the most expensive aspect of digital health is the system itself. So if we can go through what we're calling the pooled procurement frameworks, where the national government is procuring on behalf of the other counties, and then the counties are enabled to be able to plug into that system, it would be a good way to also ensure that we are financing our digital health. Then the other area, or the other way, would be through what we're calling managed service contracts. So for example, if there's a particular system that is required for the provision of digital health, we could approach the developer and then get into some contracts through, so they manage, like we lease it from them, and then we pay them based on some KPIs, for example, uptime. So in a month, how many times has this machine been running? The other thing is in terms of the data quality, response times, and even now in terms of troubleshooting in case of anything. What that might do to the counties, one, it would reduce the amount of resources we require to maintain the system, because then the maintenance cost is borne by the developer. And then two, we'll also get additional or the human resource, because the management is with the developer. So we won't need more hands from the counties to be able to manage that system. So those are some of the ways that the counties could explore in terms to finance their digital health. Now, on to the second question, which is around ensuring equity across counties. And this is an area, again, that is quite problematic in the country, because, as you are aware, in the current financial year, counties were allocated about 415 billion shillings, which is slightly above 15% of the total budget. So, and how the allocation to counties are done is based on certain indicators, for example, population, the marginalization index, and all the poverty rates and all that. But then the government came up with a very good model just to bring the counties that are still slow in terms of development by coming up with what we are calling the equalization fund. So equalization fund is not restricted to any particular program for the counties that it is meant for. But I would propose that one of the ways to ensure equity would also to try and through the health budget to put certain equalization fund for just digital health for counties that are still at the bottom in terms of their digital health advancement. So that's one way. Then the other thing would be maybe issues or exploring donor funding, for example. So counties could also approach donors, and I know there are quite a number of donors that are working directly with counties on matters health. So if you could work with donors to ensure that we can be able to get equitable financing for health. Then the other area that could ensure equity is through shared services. So this could be multi-tenant platforms where we are talking about data exchanges, we are talking about the hosting rights, cyber security operations, so that weaker counties can be able to replicate the back-end functions that are already been enabled by the national government. Then the last one I would mention is in terms of technical assistance from the national government, because again, digitization comes with a lot of technical requirements. So if we could get support from the private sector, from the national government, to support counties that are still slow in terms of digital advancement, to ensure that we can be able to be at the same level, or at least equitably, in terms of our digital advancement. And on top of all that, we cannot do that without proper governance. So at the apex would be to emphasize issues around the transparency in terms of revenue allocation from both the houses of parliament. There should be ways or mechanisms to also hold these counties accountable, where we are ensuring that they are publishing and periodic annual scorecards, and also having very verifiable indicators that we as the people can be able to follow through, just to ensure that whatever support they are getting from whichever quarters is put into the rightful area that it was meant for. So I would stop there for now. Thank you, and back to you, Martha.
Thank you very much, Bwana Osedo. I want to extend the question to Dr. Wamishwe. I'm not sure if it's part of your mandate as the Digital Health Agency, but are there any steps that we are taking towards ensuring that we have adequate or progressive financing towards the promotion of digital health in Kenya and especially in counties? And as she thinks of that answer, I would want to ask you to prepare any questions you may have as the audience, so that there is already one question, a pertinent one. So you can answer that as we get the mic to our audience.
So, yes. Yeah, thank you, Martha. And the question you've asked is something we get asked all the time. Sustainable financing for digital health. We've addressed it in two places. So the Ministry of Health has a digital health strategy that's not yet signed, but basically pretty done. And it's well addressed in there what exactly we are thinking about the sustainable financing component. But the other bit that you can now find that answer is in the DHA strategic plan that we launched earlier today. I see George Owiso there. He really worked on that plan, and also the Kisumu plan. And I think I would like to give him this mic so that he can respond to something related to that. Yes, James. George Owiso, next to you, probably has has a lot more answers, but it is something that we have definitely addressed in both documents. Beyond the documents, one thing with financing is when you start realizing that investing in digital health is not a waste. The ROI has been shown to, the return on investment is is high, it comes back. But the biggest return on investment when you do digitization is when you realize that data, we like the cliche word that data is a new what? Oil, oil, black gold, what. But we only say it. I wish as Kenyans, we would appreciate what the value of utilizing data that we have collected to make insights and then do something about it. We don't do that much. And when you look at other countries, developed countries, they really invest a lot in data systems, and they actually use the data that they collect. So that for me is when we reach there, is when I'll begin to say, yes, this is something that we have worked on. And once people see the return on investment, investing and putting in resources for that is not a problem. But it has to be done in a systematic way. And remember what I started with, you cannot invest in something which you don't understand. Understand your terrain, digital health terrain, and then know what you are lacking, know the plan that you want, and then know what you're lacking and where you can get that resourcing from. The good thing with digital health, when it's working, it pays itself back. It's easy to tell somebody, if you have an app, like let's say the apps that we use, women, I know we have this place where you get your gas. Mm-hmm. I use an app to get my gas. Mm-hmm. So once it's effective, the gas comes, I order, within 10 minutes, the gas is outside my house, I get it in. Even if you tell me to pay 100 bob to bring that gas, I don't see a problem paying for it. I'll see a problem paying for it when you are ordering for gas, 2 days later, the gas has not reached, you're making so many phone calls, nobody is responding, then I will not want anything to do with that app. But for digital health, once it works, once it's delivering what it's supposed to be delivering, even if you ask somebody, pay 10 shillings, they don't mind because they can see what it's bringing, the value that it's bringing. So that's a part of financing that nobody ever looks at. We're always looking at financing donors, PPP. I'm not saying that you've done a really good job, but financing is also from us, the users. We wouldn't mind paying as long as it's bringing in the positive effect and bringing in what we are expecting. But let me just allow George to say one or two things. Thank you.
Thank you, Dr. Wamis, for putting me on the spot. I was comfortable. You were sitting up there. So, I think the issue of financing and sustainable financing, we have talked about financing for a long time, but what we would like to see is sustainable financing for digital health. The documents, the policy documents Dr. Wamesha has mentioned have several things in common. One of the key things is that internally generated revenue or investing for it so that we see it as a valuable service to pay for is probably the most sustainable approach to financing digital health. That it requires an investment, but for us to sustain it, it has to provide value for us. Very few people, and apologies to use this, people have not stopped using M-Pesa. It has a fee, but it serves a purpose. If you are as old as I am, you remember the days of money order and your mother having to go to a post office to withdraw it. I am that old. I am very glad to pay a fee for a transaction because there's efficiency, it is quick, and it is safe and secure. So I think the most sustainable approach to digital health is investing in it and ensuring that it pays for itself. Having said that, we are also learning that what we call donors, and allow me to correct the panelist, we no longer have donors, we only have partnerships. Because the traditional idea that there is a benevolent person that would invest in your infrastructure for nothing doesn't exist. The reality is that it has to satisfy a need they also have. So it's a symbiotic relationship. So we want to get into partnerships where we are not giving more than we are getting. And that is the partnerships we are talking about. So we'll still build on partnerships. So the partnerships could be with persons where there is no profit motive, that is the non-profit sector, or partnerships with for-profit entities. Basically, we are telling them, we have a captive market. Invest, and we will facilitate as you recoup your investment. We also have this option of not taxing people to finance, because he said payslips are suffering. So the reality is, if payslips are suffering, then why can't we have pay per use? So that if this thing has value, somebody invests in it and it pays itself back. Sometimes people think that is a bad thing. Yet we encourage our mama mbogas to sell mboga from the shamba at a profit. Why is it bad for digital health for us to do the same thing? So where I come from, where I sit, and my perspective is that the most sustainable investments in digital health have to be self-paying, and then the second have to be the partnerships. Budget allocations are very good, but you realize that if they translate to tax, then they become very unpopular quickly, especially if people don't see value, then everybody is trying to impeach the governor the next day for imposing assess or diverting resources which could have been meant for, could have gone to vijana, inua vijana, or inua wamama, which are very popular with the population, but not necessarily the health of the population. So that is my perspective on sustainable financing, partnerships, investment, but of course allocations where possible, so that it also has the political will. But direct allocations, we know what county budgets look like. No county can finance its own. But facilities can improve efficiencies by collecting more money. You've heard the stories of facilities which digitalized. They suddenly have a jump in revenue. So they can pay for their own digitalization. That is the most ideal because counties will not afford to digitalize every single facility. Thank you.
Thank you very much. Can move on to you.
Thank you very much. And it's important we look at what has happened before in terms of digital health and where it has gone and come. I'm advantaged. We worked with Joyce. I'm not an IT guy, but the company was IT, and I learned a lot. Where we were using a system to remind the patients of ART, where to get their ART, when to remind them, and also messaging that, with something that tells you about what the health issues are. Now, I'm for digital health. I have no problem. My mother, she's 88. So, first of all, she had paid for NHIF. Now here she's been told SHA. So when I went and explained to her how to change SHA, she is no, never mind. She's a medic, a retired medic. But no. How I give my fingerprint? What do you think they will do? No, I'm talking about. There's that group of, and they're the ones with the money. I myself could not get her until I got my son, the grandson, who now tells her. Now came part 2, where you could do it online. And I said, no. I need to go. I want to ask that, that particular person the issue. And that's the same thing now with the digital health and where it comes from. And these are things that people actually need to know. Where I'm diagnosed and I need an opinion from Dr. Joyce or somebody else, where you send the documentation, the electronic, and it is redone. So I think it's important to show what it is. I do not buy into his idea that we can't afford. We will afford, and we must afford. And remember, we are a middle-income country. We have gone for UHC. Okay, so that's the only way that we are going to be able to deal with a lot of these issues. The problem is, how are we going to get the population to know? That's number one. Number two, the information. Again, let me come back to SHA. So here I am. I go to Roiro. I take a friend of mine to register in SHA. Of course, I'm spectacle. So he's asked questions and he answers. So I decided I'm going to follow the same. Remember, this is information that is being put in so that I can have my service. So I asked, do you live in a stone house? I said, no, it's Mabati. Never mind, I'm in Lavington. And it kept on. Do you have income? No. And all this. It came to 500 shillings. My friend, it came to 300. Of course, now it's mandatory for the 500. So sometimes the authenticity of the questions asked, and that is why Joyce can tell you, when we do surveys, you ask that question, you answer, then you wait a bit, you ask down there so that you see whether it correlates. So now, for digital health to continue, the cost-benefit analysis must be done. And let's not waste time. We already have countries that have stepped far in digital health, like South Africa, and I think Ghana and Nigeria is also trying. Find out what they are doing. In the same manner, all other countries came to learn about M-Pesa, for it to be taken into their place and for it to be able to go. Now, that notwithstanding, Joyce it's because you've been in the area. You're a doctor. But that guy who's going to graduate this year, what does he know about digital health? So how many doctors out there understand the issue of digital health? So again, we have to reinvest in trying to bring up these people. Yes, it may be expensive in the beginning, but it will be it will be much cheaper in the long run as we go along. And I think that is the most important issue. And then thirdly, and let's be very frank, you in the Ministry of Health, there are some of your colleagues you try and they have they do not they don't understand. I'm in the health sector. I'm a health economist. The guy in the Ministry of Finance does not understand when I'm telling him, let's put a budget, in these programs of HIV, TB, and malaria, especially. When he looks at his bank balance for Global Fund, which is for 3 years, he said, boss, you guys have money. You let us deal with. So you understand that knowledge, I think, is very important. So we need to get the information out there. Then also, as you're moving, get somebody to go to the vernacular radio stations and let them explain. I'm telling you, those people in the village and they listen to those expert issues. And I think that is what the most important is. But the cost-benefit analysis of what the saving will be is very important. When do I talk about cost-benefit? Today, we are able to push for funding into HIV, TB, and malaria because before we started, some hospitals or most hospitals were between 50 and 60% of bed occupancy was the cases of HIV. But when treatment started, it completely went down. Now we are seeing the bed occupancies from the older generation, the ones with now the old age ailments, the ones that come about. So I think that is the biggest. We can do all the research, everything here, but it needs to have that cost-benefit analysis. And because you've already done the research in these 3 countries now, do a cost. The cost, I can help in that. So that the figure makes sense at the end of the dot. Okay? When also we are looking at the issue of SHA, that data collected will be able to inform the planning, to be able to show, like where I come from, Muranga, we have problems of jiggers. So it will show that that amount is what has been spent out there, or whatever the ailment is, so that now, for intervention purposes, you can put in more money. I think that's the most important thing about digital health.
Thank you very much for those comments. There's emphasis on a cost-benefit analysis for digital health and a lot of public education, which I think is being reiterated a lot.